Okay. Hello, good evening, everyone. It's a great pleasure to welcome you all for this very exciting scientific webinar, New Age Management of Prostate Cancer. So it's a pleasure and welcome Dr. Srivatsa Narasimha. He is a consultant uro-oncologist and robotic surgeon, Sri Shankara Cancer Hospital and Research Center in Bangalore. To give welcome and introduction note. So it's over to you, Dr. Srivatsa.
Yeah, thank you, Geetika. A very good evening to all of you. Thank you very much for accepting to be a part of this program. And as we all know that, a lot of things are happening in the sphere of prostate cancer management with new ways to do surgery, new ways to do neoadjuvant treatments before we deliver definitive therapies, new technologies and techniques to do even radiotherapy, new treatment modalities that are available, and the way we need to time them and sequence them to optimize outcomes. So I think it becomes more and more imperative that we keep discussing about it and learning from experts from time to time. And we have all gathered here for the same reason today. Again, without wasting much time, I welcome you all for this program and thank AstraZeneca for arranging the whole event. Over to you again, Geetika, to invite the first speaker.
My voice is audible, sir?
Yeah. Okay. I think Mahendra is ready. So I think I will. Good evening, Mahendra.
Sir, can we introduce about Dr. Shyam Kishore Srivastava? So he's a chairperson.
Yeah. Sorry, I didn't have the program flow with me because I'm just using my phone. Sir, good evening, Dr. Srivastava, sir. Srivatsa here.
Good evening, Narasimha. Nice to see you all. I mean, all faces are known. So, Geetika, I think no need to introduce me.
Yeah.
We all know each other very well.
SK Srivastava sir is a very senior radiation oncologist at HCG Hospital in Mumbai. Sir, I request you to please take over the proceedings of the first session and handle the proceedings, sir.
Thank you, Dr. Narasimha. I think it's a really lovely program, and I must congratulate you, Dr. Narasimha, for formulating this program. And I'm sure a lot of people will benefit with this. And thanks AstraZeneca for organizing this. So rather really going much, I would like to really invite Dr. Mahendra Pal. He is a uro-oncologist at Tata Memorial Hospital. And I'm sure he will give you some insight of unleashing the controversies of LHRH agonist and antagonist. So Dr. Mahendra Pal, please take over and start.
Thank you so much, sir. Sir Narasimha, Srivatsa and AstraZeneca. I'm not able to share my slides. Can you make me a co-host, please?
Technical team, are you there?
Yes.
Yes, please help out, Dr. Mahendra.
Sir, please share your slides, sir.
No, I can't. Host disabled participant screen sharing.
Now, sir?
Yeah, I can share.
Okay.
So my slides are visible now?
Yes, sir, make a full screen.
Yeah, sure. So good evening, everybody. So not wasting much time, today's talk is on unleashing the controversy, LHRH agonist and LHRH antagonist. As all we know that prostate cancer is the second most cancer in the world, even in India also. And incidence is rising, and approximately 1 of the 15 patients as a 65 is involved by the may have prostatic cancer. And this is the natural history of the prostatic cancer from the high risk to high risk localized, locally advanced, and metastatic to CRPC stage. And the treatment options are the spectrum is from active surveillance to watchful waiting to surgical part, radiation part, and the chemotherapy. And now the chemotherapy has many treatment options available at present. So this talk is about the hormone therapy. So we will concentrate about the hormone therapy. So as again, we all know that there's a various methods of achieving hormone, doing hormone therapy for the prostatic cancer. And out of these are the surgical castration, removal of the testicles, and the medical castration. Out of medical castration, the agonist, leuprolide, gosylin, tutorelin, and hysterelin, and the antagonist, the Relis group is important. And we are going to cover in the next subsequent slides only about these two groups. So as the hormone therapy targets the gonadal axis cycle from the pituitary to the testicles, and the main aim is to reduce the formation of testosterone level. So what these two drugs do at the level of pituitary, they block the secretion of the LHRH by the agonistic method and the antagonistic methods. So we will explore their role for localized, locally advanced, and the metastatic prostatic cancer. As we can see, for the localized disease, there is a 40% improvement of 10-year progressive overall survival versus the RT, because the hormone therapy generally used with the radiation therapy, not with the surgical. Recently, people are using a neoadjuvant hormone therapy for surgery, but it is not in guidelines, so not practice over the world. But definitely with the radiation therapy, hormone therapy regularly used, should be used. So there is a 40% improvement in the OS with the RT alone in the localized prostatic cancer. There is a EORTC trial which studied the radiotherapy with hormone therapy compared to radiotherapy alone with the hormone therapy, and they found that there is approximately a double, more than double response for the disease-free survival, and approximately 3 times reduction in the prostatic cancer mortality when we add hormone therapy with agonist to the RT. And there's again there is almost 20%, 10-year survival when we use gosylin or agonist with the radiation therapy. The DART trial also showed the same thing, the high dose radiation therapy with short-term or long-term gosylin hormone therapy increases survival. As we can see, the two arms were there, one-to-one randomization. One has a RT plus gosylin, and other has a RT with the short-term and long-term hormone therapy. And we can see that long-term hormone therapy again increased survival by the 9%, and also the overall survival by the again 9%. Now coming to the locally advanced prostatic cancer, as we can see, there is a 46% reduction in the risk of progression over 10 years with the adding the ADT with the RT compared to RT alone. And there are 3 trials are there: RTOG, TROG, and GETUC FA trial. And we can see this RTOG trial, the gosylin was added with the flutamide with the radiation therapy compared to RT therapy alone. And in the TROG trial, we add the same drugs, but with the duration of the hormone therapy, that 6 months before the RT and 3 months before the giving RT, and compared to the only radiation therapy. Median follow-up for 5.9 years. As we can see, the right side is left is the RTOG and left is the TROG trial. So if we see the prostatic specific mortality was approximately 8% reduced when we use the ADT with the RT, and in the TROG trial there was a 51% reduction in the risk of prostatic cancer mortality in the long arm ADT. Again, coming to overall survival, there was approximately 8% overall survival in the RTOG trial, and again the all-cause mortality was reduced to 29% when we use ADT compared to 42% when we don't use ADT. The GUTEC trial studied the same thing with the similar 1.1 randomization and follow was almost 5 years, and they also concluded that progression-free survival was approximately 15%. 15% more with the radiotherapy alone, and in other words, there was 46% reduction in the progression or the death with the adjuvant hormone therapy. As you can see the forest chart, it favors towards radiotherapy plus hormone therapy. Coming to the metastatic prostatic cancer, as we know, the hormone therapy is the backbone of the stage for metastatic prostatic cancer, and it is all modality as effective as the gold standard of surgical castration. There are few trials studies has been they compared agonist with the orchidectomy, and they found almost a similar result, that both have a similar outcome in the recurrence rate, time to response, median duration of the response, mean time to treatment to failure. Only the Cassary et al. Found that median time to treatment failure is less with the goserelin, but other study was it was equal. So in short, what we get that adding hormone therapy, basically agonist in localized disease, having 40% improvement in the OS survival. In locally advanced disease, it is 46%, and metastatic prostatic cancer, it is a part of the standard of care for a long time. It is a part of also part of the standard of care at present. So if is the recommendation by the NCCN, EAU, and ESMO and the ESCO guidelines, they all recommend to add hormone therapy, whether agonist or antagonist, at least with the adjuvant therapy, like radiation therapy or the any other therapy. And for the stage 4 disease, they recommend both agonist or antagonist, and they do not specifically recommend for any of agent. Only thing is that these injections should be continued lifelong till the patient is alive. Only the drawback. So these are the spectrum of the drugs. So goserelin dosing and administration, basically it's the agonist, and agonist can be injected in a 3 monthly or 6 monthly dose, and it has an implant which has dispersed the drug in 3 months. However, in Degarelix, the dose is given every month, and that is the main drawback, which may have a frequent injection schedule and having a more adverse injection site reaction. Coming to efficacy and the evaluation, goserelin or agonist versus antagonist. There is a head-to-head comparison done in the trial. This is a long table. So what I made only these two differences. The patient Degarelix showed more rapid decline in the testosterone level and PSA level compared to goserelin. However, in long term, it is almost similar. And Degarelix could not prove non-inferiority to the goserelin for the co-primary endpoint like testosterone reduction. Coming to again efficacy and safety, as we can see that the frequency of injection is much more with Degarelix compared to the leuprolide or the agonist. And there is a faster testosterone responses with antagonist that equalizes after 14 days compared to the orchidectomy. And this response found in both agonist and antagonist. Only thing, again, this study concluded that Degarelix injection was associated with the high rate of injection site reaction with an IM leuprolide compared to leuprolide injection compared to 40% versus 1%. Coming to the safety, injection size reaction, the one theory was proposed with the Degarelix that it produces anti-Degarelix antibodies that is found in 10% of the patient have after 1 year of treatment, and 30% patient of the 5.5 year of the patient. So that is the proposed mechanism why Degarelix has more side reaction compared to agonist. The same thing about the cardiac safety. There is a long waiting. The pronounced trial is showing their result, and they found that there was no much difference between the cardiac toxicity, whether we use the Degarelix or you use the agonist, and it was found that approximately 50% with localized prostatic cancer and approximately 27% with locally advanced and 20% of stage 4 disease have a cardiac event. This study from the China compare efficacy and safety of Degarelix in patients with prostatic cancer, and they found that incidence of a cardiac event slightly more compared to the leuprolide. As we can see that the most common side effect of cardiac disorder, which occurred in 5 patients, 3.5% Degarelix group, and only 2% with the goserelin group. So the safety points are there. The incidence of treatment emerging was higher with the Degarelix than with the goserelin. The most common side effects were cardiac disorder, which occurred more in the Degarelix group, and 2 patients has a increased PSA level who received Degarelix compared to the goserelin. What about the metabolic disorders like diabetic cardiovascular disease? So again, this study found that agonist has a more incidence of diabetes and diabetic incidence, as we can see in this chart. Myocardial infarction, but again, it is compared to oncrectomy, not compared with the Degarelix. But compared to oncrectomy, agonists definitely have more incidence of diabetes, myocardial infarction, as well as cardiac death. If we compare both antagonist and agonist, so we can see that castrate level achieve faster with the antagonist. There is a no flare with antagonist. PSA failure rates are a little bit higher towards the agonist, but we can see that there is a 40% increase local site reaction rate. Serious complications are almost similar. Again, administration is monthly versus 3 monthly or 6 monthly. So if we can conclude, or we can just make some idea about this presentation till now, that all LHRH agonists are equal. However, antagonists are important in the patient who needs rapid reduction of testosterone level, like patient with the severe symptoms with impending emergencies like spinal cord compression or impending paraplegia, or having severe bone pain and bladder outlet obstruction. What guidelines says, guidelines also recommend the same thing. One should recommend ADT or hormone therapy immediately when a patient has a stage 4 disease. But any form of therapy, whether it is a agonist, antagonist, or oncrectomy is done, is no recommendation about that. However, antagonist should be considered specifically in the patient with the impending cord compression and the severe bladder outlet obstruction, and maybe who are having severe symptoms, where you don't, any doctor doesn't want any flare up of the symptoms because of adding agonist into that. So in conclusion, LHRH agonists are at present at the most widely used form of the medical ADT. Definitely surgical casting is the most commonly performed. Gossaline is a widely used and maybe that is one of the oldest one, and largely evidence based on the gossaline, this drug only. Degarelix has challenges like injection site reaction and inconvenient monthly formulation, but however, it is as effective as total oncrectomy in reducing the testosterone level and the PSA level and alleviating the symptoms of the patient. And the evidence of this regard of cardiovascular safety has so far shown comparable result with the agonist, and maybe in future we may get a similar or maybe different result. So I want to conclude by saying that the choice between LHRH agonist and antagonist must be individualized, must be based on patient comorbidities, patient symptoms, and the disease burden. Thank you.
Thank you, Dr. Mahindwal. It was really wonderful, very concise, and
Thank you, sir.
within the time frame. So it's lovely. I think one thing is that those who are listening may put their questions in the question and answer, so that Dr. Mahindwal can answer. If there is something which is very quick, we have 1 or 2 minutes, we can have 1 or 2 questions if somebody is asking. Dr. Mahindwal, I think the one thing which is very positive with Degarelix is that you don't need, you are not thinking of the flare. So I said that is one thing, and maybe 3 monthly. So are there a possibility that this can also be 3 monthly injection or 6 monthly or a year? Now the yearly injections are also there.
Maybe, sir, they are trying. I spoke with their people who come here to meet us, and they generally say the process is going on, but how much time it will take, even they don't know. Yeah. But definitely, if there is a now also the generic brand has come of Degarelix. So suppose that if they have a similar dose, so definitely maybe in future after the oncrectomy, the second choice will be the antagonist.
Yeah, right. Is there any other question somebody would like to ask?
Question, sir. Srivatsa here.
Yeah, please.
Yeah, Mahendra, how seriously do you, or how practically do you encounter cardiovascular events in patients on ADT? How often?
So normally what happened, once patient started on ADT, so generally they in Tata hospital, they follow with the medical oncologist. Okay, but it is now, but previously when we were used to follow the patient on the hormone therapy, so we found that definitely the patient having a receiving agonist, they have more common metabolic syndrome, or maybe by that time the antagonist was not introduced or frequently used, right? So maybe if ADT, all ADT has a similar side effects like metabolic syndrome, whether it is a orchiectomy or Degarelix or antagonist for long term. So I don't think so at present there will be any difference between the metabolic syndrome, whether it is an agonist, antagonist, or the orchiectomy, depending on the how we counsel the patient about the importance of physical activity and remain active, and to counsel them about how these side effects affect the body actually. That is has important impact on the overall outcome.
Yeah. Have you formulated a particular protocol to screen in or screen out patients to receive either drug like antagonist or agonist, or
Like
it is still a
screen in
practitioner?
and out. What does it mean by screen in and out?
Hence, now is there a protocol which everybody in the department adheres to, or you as a clinician seeing the patient assesses it and then takes the call?
Yeah. So what it is not possible me to see all the patient. Only the patient who needs attention or needs some advice, which juniors cannot handle, that we talk to the patient. But generally, it is we have our residents and our fellows like that. They have to explain all the options: surgical castration, agonist, and antagonist, along with their frequency of injection and their side effects in detail. And then the patient has to choose which therapy he wants, either a castration, surgical castration, or medical castration, and out of them, which he likes, monthly Degarelix or this one agonist. But definitely the patient having severe symptoms like impending cord compression or severe LUTS, definitely those patients we try to avoid using agonists.
Okay.
Yeah, Dr. Mahendra, nice presentation. Just one question. The risk of the prostate developing into castration resistance, Degarelix versus Goserelin, that is LHRH antagonist versus LHRH agonist. So the risk of transformation into a metastatic or a castration resistant prostate cancer, which is Degarelix versus Goserelin. Direct question. Is there any data, any literature?
So there's no data, but one study I came across where in biochemical recurrence on some disease where there was crossovering of Degarelix to the Goserelin.
Right.
In that study, it was shown that the changing of the drug leads to increased OS in the Goserelin group compared to the Degarelix group.
Right.
So there was something 20% 5-year OS improvement with the Goserelin compared to the Degarelix.
Right.
Dr. Mahendra, there is one question from the attendee audience. Any scope of Relugolix, anything in the horizon is the question.
Yeah, definitely. In India, definitely there is a scope. Everybody wants oral medication. The only thing is India is, I think the price is the important factor. And once it is available, I think the people will like to have oral medication than the injection. Anybody will like having oral medication than the injection.
Okay.
Okay, thank you, Dr. Mainpal. It was wonderful.
Thank you, sir.
I think we'll go for the next one, Dr. Pranav Chadda. He is going to speak on prostate cancer patient journey, multidisciplinary team approach, and the GETUC and AFU16. Dr. Pranav Chadda is the radiation oncologist at Kokilaben Hospital. Pranav, over to you, please.
Thank you, sir. Thank you to AstraZeneca. And everyone can see my screen. I would just ask.
Yes, sir.
Yes, all right. Sorry, pardon me. All right. So good evening to everyone. Thank you to AstraZeneca. Thank you, Dr. Narasimhan. And thank you, sir. Thank you, Srivastava, sir. My topic for the presentation is prostate cancer patient journey with a multidisciplinary approach, and the GETUC AFU16 sort of the trial and the inferences. So as we know, prostate cancer is ranked as the 4th most frequently diagnosed cancer worldwide. This is as per the 1.3 million new cases per year, making it the 2nd most frequently diagnosed cancer, second to the lung in males. And it's the 5th leading cause of death. So because of the prevalence, the number tends to develop into a castration resistant or the metastasis, and the death also is now sort of significant as the fifth leading cause. And there is a striking geographical variation. The Asian belt, especially with us in India, it's not as high as when we look towards the Western Hemisphere, in Brazil, in South Africa. The mortality also, fortunately for us, again, it's not in the high zone. The epidemiology. So from the Indian point of view, the prostate cancer ranks 16th incidence wise in India, with a reported incidence of 25,696 cases, and the deaths are 17,184. Almost all patients with metastatic prostate cancer go on to develop a castration-resistant prostate cancer, and the overall prognosis of the metastatic CRPC remains poor, with a median survival of 1 to 2 years. Little is known about the prostate cancer etiology, but the increased risk appears to be associated with increasing age that we all know, the genetic and the lifestyle factors. There is an ethnicity, especially from the Western point of view, that the blacks, the black race is more prone. There is a hereditary predisposition as well. We are learning more about it. The diet, the obesity, the cigarette smoking, yes, they are associated factors. So risk is higher in men who have a family history of cancer, similar to breast, especially if the father or the brother had a cancer or a prostatic malignancy. And simple, just a primer slide, what is the benign prostate hyperplasia and the prostate cancer? BPH refers to a non-cancerous increase in size. It's a physiological or a natural process. Prostate cancer refers to the cancerous enlargement of the prostate gland, and there are zones in the prostate which actually sort of dictate the symptoms and show it differently with respect to either of the etiology. So what is the common age group for prostate cancer? Prostate cancer is a disease of advancing age. There has been a statement that if all the males live beyond, say, 110 years, we all might be having prostate cancer. This was one of the statements from Johns Hopkins. The commonest age group right now, as per the detection, is 60 to 80 years, can occur 50 to 60 years, rarely less than 50 years of age. Yes, there are cases, but yes, the commonest age group is 60 to 80 years. And there are two categories of patients, especially with the screening programs. One is that we find a raised PSA as a routine test, or there are symptomatic, there are sets of symptoms with the LUTs, we call it the lower urinary tract symptoms. If the zone is on the posterior side, can lead to constipation, retention of urine, difficulty in passing of urine. And if there is a metastatic disease, or if there are sort of a systemic spread, then we see sort of a weight loss, generally tends to involve the lumbar vertebrae, the pelvic bones, and with the loss of appetite. So we can sort of think in those lines from the syndromic point of view that it can be either a locally advanced or a metastatic presentation. The examination begins with the general examination, the performance status, weight, the distal rectal examination to sort of think or to find out the size of prostate, the nodularity, consistency, firm versus hard. The BPH tends to be soft. The rectal mucosal involvement also is a part of staging, which sort of gives us a guidance towards the staging. However, the PSA, which is done as a blood test, has been used as a screening test also, with a free and a total component. It is specific to prostate, but not to prostate cancer. As we all know, it can increase in a prostate infection, benign, the BPH, and the malignancy itself. And this is how sort of a rule of thumb that less than 50 years, the normal range is 0 to 2.5, 50 to 60, 0 to 3.5. There is a cutoff that is defined, commonly used as 4 nanogram per ml. We should do a free to total PSA sort of a distinction. 60 to 70 is 0 to 4.5, and more than 70 is 0 to 6.5. The investigations which are routinely part of the workup are the MRI pelvis, the impressions of benign versus cancerous enlargement of prostate, the PIRADS grading score, use of the diffusion weighted imaging as well. There are to find out whether there are single lesions, multiple lesions, location of lesions, the spread involvement to the surrounding structures, to find out the lymph nodes as well, because that upstages the disease, the condition of the bladder with respect to the long-standing urinary symptoms, sometimes on a background of the BPH itself. A truss-guided biopsy, minimum 12 biopsy samples plus a targeted biopsy from any lesion to find out both lobes which are affected so as to stage it as per the TNM criteria, the number of positive biopsy cores, the grade of biopsy from the Gleason's point of view and to assign an ISUP score, the PNI, the perineural invasion, which if it is absent or present. The steps of cancer treatment: as the diagnosis, we confirm the diagnosis, we stage the disease, we find out whether it's locally or loco-regional, then we do a metastatic workup. The PSMA PET CT is used, or a CT chest and abdomen. PSMA PET CT now, since it's getting readily available, it's sort of getting common and part of the routine workup. And then a combined information with respect to the PSA level, the TNM staging, the grade. So we stratify in terms of the risk stratification. This is from the basic anatomy. So the most common site of prostate starts in the peripheral zone, and also sometimes in the transitional zone, which causes a different symptom. But yes, peripheral zone is what is the location of the prostatic malignancy. The central zone is more for the BPH. So the main treatment modalities, if we look at numerous guidelines like EAU, NCCN, so we have to sort of risk stratify as low risk, very low risk, low risk, early stage. We can go for active surveillance versus radiation alone, brachy versus a radical prostatectomy. The intermediate stage, I'll just show that in the next slide. We can go ahead with either radical prostatectomy to find out whether the chances of lymph node involvement, then radical prostatectomy plus a pelvic lymph node dissection is the treatment of choice, versus depending upon the age, the life expectancy, we can sort of start on the hormonal therapy, and versus radiation alone. There is the high risk cancer prostate, a very high risk cancer prostate, and then there is a stage 4 metastatic disease for which a lifelong hormonal therapy versus bilateral orchiectomy, the agonist versus the antagonist that we've already discussed. So the hormonal therapy, if we see, it always forms the backbone for the all stages of prostate cancer because it is hormonal dependent. That is why. So it comes into the picture from the logical point of view, which has been tested and sort of been validated in trials. From the radiation point of view, I'm being a radiation oncologist. Sorry, this slide is slightly a prior slide, but we've got good technologies now. Sir has seen, Dr. Srivastava sir has seen the evolution of radiation to start off with just the bony landmarks, but things have improved. We can now see everything. We can modulate our dose. We can literally dose paint with respect to the target, the prostate, the lymph nodes. We can now achieve a higher dose to the prostate, to the lymph nodes. There is a concept, a theoretical concept known as stereotactic body radiotherapy, where we can give a higher dose, which also has an anti-angiogenic mechanism, so as to give a better biochemical disease-free recurrence. That is how the endpoint of SBRT has been evaluated, which actually or sort of is a surrogate marker for overall survival. Different types of technique started off with 2D, the bony landmarks. Then we came on to the conventional radiation look, as if we can all appreciate the dose cloud or the dose. It's just like treating APPA. The 4 fields does help to reduce, but yes, the tissues are quite sort of, the OARs are sort of getting irradiated. Then comes the intensity modulated radiotherapy, with which we can sort of dose paint, giving a mathematical problem to the planning system, with which we can get a very tight and a conformal dose to our targets and sparing of the normal tissues. So as you can see, prostate and the lymph nodes are sandwiched between the bladder and the rectum. So this IMRT gives us improved conformity, improved clinical outcomes. In fact, IMRT was the technique which was tested in prostate by Michael Zalewski et al. In a randomized controlled trial, which increased the overall survival, the hardest endpoint, with less complications, lesser side effects. The image guidance with the role of the cone beam CT also helps. So this is the This is the IMRT, as we can see, conventional radiation, and we can very well conform, save the bladder and the rectum and the bowel bag. The cone beam CT, the CT scan, which is attached onto the machine itself, has been a boon. It takes a picture there, takes into account the setup errors and rectifies it. It also can deliver the plan of the day if there is a different bladder filling or there are different rectal states, whether it's full versus empty. So these things can be taken into care to increase the therapeutic efficacy, to increase the tumor control probability is what we radiation oncologists say, and to reduce the normal tissue complication probability. So this is how the planning CT looks. We acquire a cone beam CT, we fuse it, we co-register to the planning CT. We find if there is any difference. There are 6 degrees of freedom that can be corrected. There are a multi-leaf collimator concept which can fine-tune the beam. There is a triple F beam, a flattening filter free beam. So the end point is to achieve a higher dose to the target and minimal dose to the organs at risk. The current radiation therapy for cancer prostate has been 60 to 65 gray over 4 to 5 weeks. Earlier, it was 2 gray per fraction. That is our conventional fractionation, but we have started hypofractionating also from a radiobiological point of view. There is a alpha by beta concept in radiobiology, which is low for the prostate. So that means it will respond to a higher dose per fraction. And then we have extrapolated that alpha by beta concept into giving a very high dose, like a 6 gray or a 7 gray, which we call it as stereotactic body radiotherapy. But these kind of high doses should not be attempted with the 2D, the bony landmarks. Otherwise, the organs at risk, they will suffer, and we will have inferior outcomes with regards to the toxicity. So the higher dose, as I said, by the IMRT was shown to improve the percent PSA relapse as you go up the ladder. That is, if you increase the dose, you get a better PSA relapse-free survival. The grade 2 rectal toxicity also depends upon the technique, but it tends to get with more intensity modulation and more technology use. The cystitis and the proctitis, yes, were there with 3D CRT, even with IMRT, but the rate has been coming down with a lot of intrafractional imaging, the plan of the day implementation. So it's how you put into the plan so as to get the better result. The grade 3 toxicities have been coming down with intensity modulated radiotherapy, with which we are sort of confident enough to give a higher dose or think of higher dose in a hypofraction or an ultra hypofractionated manner. And then the use of hormonal therapy have improved the recurrence-free survival, the case-specific mortality rate. Things have sort of improved with respect to both the radiation as well as the hormonal therapy. Also, once we look for a patient who is post-radical prostatectomy, 2 recent trials, radicals and raves, and then a meta-analysis with the GETUC trial, the ARTIST meta-analysis, they have sort of thought upon this, and they've come to this inference that we can look on to with a regular PSA surveillance and keep the radiation as a delayed salvage option only when the PSA rises. So surgery also, this is with respect to the high risk patients that we have achieved a good biochemical sort of, I would say, recurrence free sort of zone. So the commonest that we have been using in our practice has been from a Fox Chase cancer PSA definition of rise of 0.2, which has been widely used and widely practiced. That is what we have seen, or with 3 consecutive rises once we are looking at 0.1 nanogram per ml. All lymph node positive patients, once we have done radical prostatectomy, should be given post-operative radical radiotherapy, that is irrespective of the post-op PSA. This point, I'm sorry, this I would like to put an asterisk, because as per radicals rate, this is debatable. That is, we can still keep the patient on hormonal therapy and wait till we get a high PSA level. The hormonal therapy, Dr. Mahindra has discussed the options, the agonist, the antagonist, orchidectomy, anti-ADT, which should not be used as a single agent, and the CYP inhibitors. Monthly versus a 3-6 monthly depot. Majority of randomized trials done prior to GETUC were done with a monthly preparation. There was a level 1 evidence. The 3 to 6 monthly depot was thought of to sort of take care of to reduce the number of hospital visits, to provide ease to the patients. There was some concern prior from an hypothesis point of view that there might be some irregular release, or it might not be effective in decreasing the PSA. Side effects of androgen, the orchidectomy suggested by Dr. Huggins and Higgins they've received Nobel Prize for that, and it prepares your patients for the hormonal therapy. But as Dr. Mahendra also showed, and with bilateral orchidectomy, I was going through some literature that it might lead to castration-resistant prostate cancer. There have been a lot of metabolic disorders and also the psychological impact that it has. While the patients are on hormonal therapy, they have to watch a bone health by bone densitometry. They need to take the calcium and the vitamin D. We encourage the patients to do physical activity and exercise. Bisphosphonates versus denosumab, that can be an option. The cardiac issues also need to be taken care of because they have a cardiac toxicity profile. So once a echo and ECG, and a 6-monthly lipid profile and diabetic profile as well. So patients presenting with locally advanced localized prostate cancer can be offered curative treatment. We need to find out whether there is no biochemical recurrence. Surgery versus radiation can be competing. Once we find out that the patient is castration resistant with respect to the testosterone levels, we switch over to the systemic therapy, which can be docetaxel or the abiraterone. That needs to be dealt with the medical oncologist. However, if we see the prognosis, now there is a stark difference. The stage 1, 2, and 3, if we see the relative 5-year survival by stage, for stage 4, it falls drastically, if we can sort of appreciate this fact. So we need to do something with respect to the systemic disease that needs to be taken care once we see these values. Similarly, from the Gleason's and the ISUP grade point of view, the recurrence-free survival, we see there is a fall, no doubt about that. There is a discrepancy here, but with respect to the ISUP and the Gleason, it falls, sort of comes down drastically. And prostate, as we all know, and even the malignancy is hormone dependent. It's a disease characterized by multiple clinical states. We plan for adjuvant treatment. The serum PSA is the most sensitive indicator. That's why we keep on repeating it. We then tend to find out whether it has become metastatic in the event of it being hormone sensitive, or it has become a castrate resistant, and then we decide accordingly. But these arrowheads show that these are the time points that we need to consider the systemic therapy. These are the definitions as per the NCCN, ISMO, and EAU. More or less same. I tend to practice the NCCN, but EAU more or less it's within the same sort of guideline framework. I'll just go through these slides quickly. For the low risk, once we have characterized the patients as low, intermediate, high, now there is a very high risk, as we can see from the NCCN guideline. We sort of tend to define, we watch for the life expectancy. There are life expectancy tables. You calculate them. You sort of give them an option of the active surveillance versus active treatment. Radiation, yes, a competing technology. Others like cryotherapy. However, there's no randomized trial. I checked it out. That says, but yes, it is mentioned in the NCCN guidelines as well, and EAU as well. Intermediate risk, again, if the risk of the lymph node exceeds more than 5%, then I myself as a radiation oncologist would advise the patient to undergo surgery. If required, the salvage or the adjuvant radiation therapy will come later. High risk, this needs to be understood that what is the evidence. The level 1 evidence still goes in favor of hormonal followed by radiation. However, a SEER database analysis, we have a Scandinavian trial which is running and which will give us the answers with respect to high risk, locally advanced. But whenever I try to find out, the hormonal radiation still stays as category 1 from the guidelines as well. But yes, a SEER analysis recently in 2021, it's a retrospective data analysis. They've just come up with that, which says that yes, surgery can reduce the prostate mortality due to the cancer specific mortality. That is what they mentioned. However, the Scandinavian trial will give us the actual results. The locally advanced, again, the lymph node dissection is an option along with radical prostatectomy as part of the multimodality treatment. So the surgeon has to tell the patients that we need to keep on monitoring keep you in surveillance with respect to the PSA, and you might require radiotherapy. That is how things would be. First line metastatic patients. Now there is talk about the prostate being an oligometastatic disease. However, still the TNM does not categorize it as oligometastatic. Only the lung is categorized as oligometastatic. So there are two categories, either symptomatic patients or asymptomatic. For symptomatic, you start off with the systemic therapy. If there is any local problem like a bone mets causing a cord compression, then a neurosurgical intervention versus a radiation intervention, or a hemostatic RT. If there's a bleeding prostate, the radiation needs to be given along with the systemic therapy. Even for M1 asymptomatic patients, if the disease in the weight-bearing bones, and if the patient is sort of motivated, then yes, the radiation can be given. Also, the LHRH agonist versus antagonist can be offered to the patient. With respect to the castration-resistant prostate cancer, you need to confirm it with the testosterone level. You need to go ahead with docetaxel, the second line with abiraterone, cabazitaxel, give the best supportive care. Now, these patients don't fare well. So even the prostate is a slow-growing disease. Once the patient comes into this picture, then things become really difficult. Then what is the aggressiveness of the disease comes into the forefront. So these are the EU recommendations with treatment of the bone disease, specifically to use zoledronate or denosumab. With respect to the skeletal related events, to offer calcium and vitamin D supplementation to treat the painful bony mets, depending upon whether it requires a surgical intervention versus radiation. And cord compression, again, surgery versus radiation, we have to take a call on that. Prostate cancer, it tends to start off localized. Patients do stay well. We have good results in prostate, but when they start progressing, they can become locally advanced, and then this is the dark side to the prostate cancer. So the GETUC trial wanted to try out. They randomized the patients in high risk patient stratified patients, in which they did radiation alone versus the goserelin. 6 months goserelin. The primary endpoint was progression-free survival, and the secondary endpoints included the overall survival, and also the metastasis-free survival, the distant metastasis-free survival, and changes in the quality of life. The primary analysis conducted at a follow-ups of 63 months, and long-term was also going beyond 110 months, 112 months. So the progression-free survival was better with goserelin and radiotherapy, telling us that the disease has a systemic nature, and also the hormonal therapy acts at the local level as well. There was a 46% reduction in the risk of the progression or death with adjuvant goserelin post radiation. This forest plot has been shown by Dr. Mahendra. The IMRT crosses to the other side. I think we have improved on this IMRT line, and now the IMRT along with the goserelin should be to the left of the baseline. The RTOG 8610, again, Dr. Mahendra showed this with respect to the TROG. The primary endpoint here was locoregional control and not the progression survival. And again, the TROG 9601, which again was time to local failure and prostate cancer specific death, primary endpoints. Time to biochemical failure was again with respect to the PSA. The disease specific mortality with the RTOG 8610 trial was favoring the goserelin. They also used an anti-androgen plus and radiation, and was sort of favoring the goserelin, the hormonal therapy, and the radiation arm. There was also a 51% reduction from the TROG study as well, which was again significant with respect to the 6-month arm. Overall survival, however, as Dr. Mahendra also showed, again, was not significant. However, there was a trend towards the goserelin and the EBRT sort of that it was showing some improvement, and the all-cause mortality was definitely better with the 6-month neoadjuvant goserelin. So giving hormonal therapy prior to radiation 3 months versus 6 months, so that also the TROG 9601 helps us from that point of view. The ASCEND RT trial, this is from the radiation oncologist perspective, whether we can increase the dose However, again, if we are getting better on the local side, we might fail systemically. So the hormonal therapy still remains as a core component of the treatment. The EUA guidelines therefore recommends for locally advanced to give external beam along with long-term ADT, the EORTC, the BOLA trial, which again Dr. Mahinder showed, and there are several randomized phase 3 trials which have promoted the combination of long-term adjuvant ADT as a standard of care. Long-term ADT produces at least shows an increased OS as per the RTOG 8610 and definitely reduces the death due to the prostate specific mortality. And this is what again from the AstraZeneca team, that they've shown that RT plus LHRH shows a better overall survival. That is how things are. Thank you so much. Thank you. This is the end of my presentation. Thank you.
Thank you, Pranav. Thank you. It was very nice.
Thank you, sir. Thank you.
Very
Sir.
comprehensive, and you have covered practically every aspect in that.
Thank you, sir.
I'll ask if everybody wants to ask some question or somebody. I could not see anything in the question answer chat.
Sir, can I, Srivatsa here, can I
Yep.
ask Dr. Pranav a couple of questions?
Please, sir.
Yeah, please.
Thank you.
Extremely good presentation, lot of information, summarized in a nice manner and put across. Thank you very much.
Thank you.
My first question is regarding early salvage radiotherapy by radicals and rays,
Yeah.
So how comfortable are you not to give adjuvant treatment in the basis these trials now in node positive patients?
I would say with respect to the node positivity rate, and again, if I look from a critique point of the radicals and raves, which came up from D. Amico et al., they were of the opinion, and this is what I quote and unquote, and that is why I still practice, if the node is positive, that is, I would like to give an early salvage, or for that matter, even adjuvant radiation, that there is a chance of it developing into a metastatic disease. So for a nodal positivity, yes, I would like to initiate radiation sooner than rather waiting on even on the biochemical parameters, that is the PSA.
Okay. Do you consider, so in our practice here,
Yeah.
what we do is for up to 2 nodes without any extranodal extension,
Right.
we tend to wait, looking
Right.
only at the PSA,
Right.
and then kind of put them on early salvage radiotherapy if required. That I personally feel really segregates those patients who will continue to remain cured because of the lymphadenectomy alone,
Right.
versus not knowing whether the lymphadenectomy helped or the systemic therapy with radiotherapy helped.
Right.
The second point, which has been of some good consideration in the recent past, is the utility of certain genetic tests.
Yes.
For instance, Prolaris
Right.
or Oncotype DX or Decipher, wherein you can actually run these tests in this subgroup of patients, and kind of see if they have a higher chance of recurrence or not. If these, I agree that these are expensive, but this is probably a good use case scenario where you can do these tests and see if they fall into the high risk category, go ahead with adjuvant treatment. If not, then just hang around and prefer to do the early salvage. What are your opinions on that?
I have not seen in my practice or neither practice these genetic markers, Dr. Narasimha, but yes, gone through the literature, the theory, yes, it makes sense. If I may just point out the trial design of radicals and raves. So treating a high risk or a very high risk patient, there wasn't. I'm just asking. I'm not asking as a radiation oncologist. As an oncologist, if I say there was no level 1 evidence of patients being subjected to surgery, but yes, it was done. But the hypothesis itself was to start off with surgery and then to look for the biochemical recurrence thing. Now, if you look at trials prior to the biochemical recurrence failure, everyone was looking for metastasis-free survival, loco-regional control, progression-free survival. Once we got the biochemical recurrence free, the PSA, yes, things have gone on to that. Now, again, a recent trial, I'm just quoting from Tata itself, from Dr. Vedang Murthy, which is comparing pelvic versus just the prostate alone for the high risk, is looking at PSA. And however, there are two critiques to that. They say no, that recurrence, that indicator is not a very hard surrogate endpoint for overall survival. So you start looking for, again, progression. So we are again reinventing the wheel, going back to progression-free survival, the distant metastasis-free survival. So that is a critique by Dr. Rahul Tendulkar that he's given to the JCO article. So the radicals raves built upon the serum PSA as one of the endpoints, the biochemical recurrence free, and to judge the salvage radiation, whether as early or delayed. But with respect to nodal, I think the DMICO critique of that article stand its own ground. I'm sorry, that is how I think of it. So nodal, two nodes, as you said, once we read the critique, I think it's a matter of decision then how we interpret the evidence. That is how I would say.
Yeah. Srivastava sir, can I have your opinion on this? 1 to 2 nodes positive, would you go ahead with adjuvant treatment, or would you still wait for the PSA to recur and then do early salvage?
I think I agree with Pranav, what Pranav mentioned. So I think this is the common thing which is a dilemma for all of us. So I agree with Pranav.
Okay. The second point, Dr. Pranav, that I wanted to bring out is the role of multimodality therapy. I do agree that ADT and RT has level 1 evidence for high risk localized or even locoregional prostate cancer, but we need to really look at how this level 1 evidence has come up.
Yeah.
So this level 1 evidence is in comparison to ADT alone.
Yes, or even radiation alone, for that matter.
So
Yes.
so it is very hard to get a level 1 evidence comparing two curative therapies, and that's the same reason why we have not had a
exactly. So with in all humility, then we should wait for the Scandinavian trial for the results to come up, and then we employ surgery as a definitive treatment, Dr.
So
Srivastava.
I think
without any bias. Yes.
Yeah. So the bias, I completely agree that there are going to be biases, but when we talk of this level 1 evidence,
yes,
that was in an era where surgery was not uniformly practiced with the same standards. So I'm not supporting, I'm a surgeon, but I'm not supporting surgery here. What I'm trying to emphasize here is that there are several trials which have proven that multimodality significantly alters both cancer specific and overall survivals, which you yourself also brought out in your presentation.
So we read one of our textbooks. I just want to quote is by Perez, Radiation Oncology, and every new edition, especially with respect to prostate, I'm just sharing it with you, there is a debate. the chapter itself mentions surgery versus radiation, especially in the high risk zone. So the trials which have been done, including the SEER database analysis, Joby 2021, which it has come, supports surgery, but that's a retrospective data analysis. All the prospective have been a phase 2 trials, which yes, do support surgery with respect to studies. But again, if we are a bookworm and if we have to go by the book, then we should wait for the Scandinavian trial. Otherwise, if I'm
Scandinavian trial that we are talking of is already
is ongoing,
in trouble because of low accrual.
Yes.
So I don't think that the trial will complete its accrual and then we'll have some results. Again, it is not about whether surgery is better or radiotherapy is better in this regard. I feel both of them need to be employed to maximize the outcome. That is my take on this.
Right. I respect that, Dr. Nasir.
Yeah.
I do respect that. Right.
I think Rajesh has some, he raised his hand. Rajesh?
Yes, sir. So regarding the question Dr. Srivastava asked regarding adjuvant therapy in node positive disease, I think you should take the local staging into consideration, high risk pathological features such as positive surgical margins, terminal vesical invasion, and extraprostatic extension, all these things into consideration, and grade of the disease, and nodes, number of nodes positivity, more than 2 nodes positivity, how bulky are the nodes, and any extranodal extension are there. So these are the things to be considered to decide on adjuvant therapy. I think in this context,
Exactly.
CAPRA score would guide us that we are regularly following in our institute, and it is giving good results for us to decide whether to go for adjuvant radiotherapy or only ADT, or whether to just wait more watchful waiting, rather than waiting till the PSA progression and patient will be apprehensive.
Exactly. So
once
so
patient
that,
develops continence, then immediately we can go for, and we can directly start the ADT and go for radiotherapy if there are very high risk pathological features.
so
And
Dr. Rajesh, what you're speaking exactly against radicals and rapes. I'm sorry. That is how, if I have to say it in black and white, that if we just look into the PSA, and if you say that we should look into these factors, including the Gleasons, the margins, then then the PSA doesn't come into the picture. That is the conundrum. Yes, that is.
and CAPRA score would be very much useful.
Yes. But yes, the genetic markers, yes, they do deserve a mention. As Dr. Narasimha rightly pointed out, they should be incorporated like it has helped in brain, and things have changed dramatically, to put it, with respect to classification. Similarly for prostate, it would make sense. It would make sense.
I think we'll go ahead now.
Jeez.
And thank you very much.
Thank you.
Thank you so much, sir.
Discussion. Thank you.
Thank you, sir.
Next lecture is by Dr. Tejendra Singh, Senior Medical Oncologist at Apollo Hospital. He is going to speak on role of the homologous recombination repair gene and the PARP inhibitor in metastatic castration-resistant prostate cancer. So, Dr. Tejendra.
Yeah, thank you, sir. I think the slides are visible.
Yes, we can see.
Yeah, thank you. Thank you, Shivasa, sir. Thank you, Dr. Narasimha. Today, I'll be speaking on the evolving diagnostic landscape in metastatic prostate cancer. We'll be touching apart from the metastatic setting. We'll try to see in locally advanced disease also. So the diagnostic landscape is more related to the genetic things which have come up in the last few years. And my talk is mostly going to relate to the kind of mutation testing which we do and a newer thing which have come up because of that. So we know metastatic prostate cancer is a biologically heterogeneous disease, and this is something which, apart from other cancer, this is something a quite biologically active disease. If you see a metastatic CRPC patient, approximately 90% of the patient, they have some kind of genomically aberrant pathways. And there are different pathways which have been found in metastatic prostate cancer, like AR pathways, that is androgen receptor pathway, PIK3 pathway, DDR, WNT, and cell cyclin signaling pathway. So this is a small chart which shows about a multi-institutional study in which they had done a profiling for nearly 150 patients in CRPC state. And you can see different pathways are activated in a metastatic setting, and the percentage you can see varying from 18% to 72%. But the main thing which we are more looking at is the DNA repair pathway, because that is something which is the most important active pathway. So approximately 23% of the mutation were identified in the DNA repair pathway. That is something which we know, which we can target. And we are looking at not only BRCA1 and 2, we are looking at the other genes like ATM, RAD51, FANCA, MLH, MSH2, and CHEK2, which we'll be taking up later on the topic. So this is a way to tell us that when you talk about mutation in DNA repair pathways, it leads to something known as genetic instability. And this genetic instability leads on to tumor growth proliferation. So there are different ways the pathways are there. So you have single pair, we call base excision pair. We also can have bulky adducts leading on to formation of nucleotide excision repair. Then the mismatch repairs, mismatch insertion and deletion, which can lead on to what is known as mismatch repair, which is commonly mentioned as MLH1 and MSH2. And the important thing which we are going to discuss is the DNA double strand breaks. So there are two types of breaks. One is the homologous recombination repair pathway. Another is known as non-homologous end joining, or we call NHEH. The key mechanism, if you talk about DNA double strand break, is the homologous recombination repair, which will be addressing as HRR. The HRR is not only including BRCA1 and 2. There are named genes, mutations are there like ATM, CHEK1 and 2, RAD51. RAD51 further has got multiple different types, and PALB2. Now, how do we identify this HRR? Because there are different terms nowadays being used. One is known as a simple germline or somatic BRCA mutation. Then we have a panel of HRR gene panel, and there's something which is nowadays come up in a big way is HRD genomic score. And what is the use of us different things? Remember, we are now looking at this particular gene mutation in certain subgroup of our cancer patient, like in pancreas or hepatobiliary, I'll say. Then you have in prostate, ovary, and breast. We don't use HRR and HRD in almost every one of them. There are certain areas where HRD is used, certain area where HRR is used. But we normally look at something known as HRD or genomic score, because it is day by day becoming a prominent score, because it identifies the pattern of genomic damage. It's something, and these tests are principally based on LOH, we call a loss of heterozygosity, and typically includes BRCA analysis as tumor BRCA mutation. So a patient can be HRD positive, but can be BRCA negative. Apart from that, the other important gene panel which we commonly use is the HRR one, a homologous recombination repair mutation gene panel. And there are basically there was a trial on a profound trial which was lately looking at it. So HRM basically is a there are different genes which are there, and you can see here the profound trial. They have given importance to 15 genes, which includes RAD, which was around 4, which is B, C, D, and 54L, and also the BRCA mutation. So what we do normally in our testing is we look at the genetic mutation by either way germline or somatic, and also we look at the HRR and also the HRD. HRD is something which is going to become a prominent in most of the clinical setting. So looking at the prostate cancer, how much is the frequency of these kind of mutation? So these was a small study where they had taken an archival and new biopsy sample of nearly 50 loco-regional and 53 biochemically recurrent and 350 metastatic patients. And what they found was the most common mutation you can see in this nearly 450 patient was BRCA2 was dominant both in a germline and somatic. So approximately around 15%. Germline at around 9%, 7.5 in a somatic. BRCA1 was less prominent. Then comes a ATM in germline and somatic. Then is a CHEK2. So BRCA2 is the most frequent altered DNA repair gene in the prostate cancer based on the this paper. So the incidence of germline mutation in genes overall, if you see, is around 12%. So this is small paper which looked at nearly 700 patients, and they had looked at those genes which are evaluable, which can be assessed. They had assessed 20 genes, and in the 20 genes they found that around 44% basically constitute is the BRCA2. And if you see BRCA1 and BRCA2, it is nearly 50%. But the next predominant is the ATM and the CHEK2, which was around 25%. So somatic mutation was also observed, but the total incidence when you look at the mutation in a metastatic prostate cancer was around 12%. So this is the matched sample analysis of blood and advanced prostate cancer tissue samples. You can see they had taken a blood sample, also they had taken a tissue sample, and you can see on the left side the genetic or germline alteration And you can see on the right side the germline and the somatic alteration frequency. So when you see on the left side the germline alteration nearly 19, the bulk of the patient had basically BRCA2. On the right side also the BRCA2 was predominant both for germline somatic. So the higher frequency of DNA alteration identified through the matched tumor sample, germline plus somatic, it strongly argues that you should do a tumor genomic analysis in patients who are having advanced prostate cancer. So this is a genomic profiling of primary prostate tumors from the patient who developed metastatic CRPC. And you can see on the left side and the right side non-metastatic and metastatic setting. They compared 49 pairs of same patient tumor, primary tumor and metastatic CRPC biopsy. And there was a limited intra-patient heterogeneity was observed between the primary tumor and the metastatic CRPC. There was no significant difference in the mutations which were found in the primary tumors who developed metastatic disease or who presented with de novo metastatic disease. So basically it is trying to tell that, you know, you can use a archival tissue also for mutation testing. So you can see a cohort 1 and cohort 2. Cohort 1 was the patient who had without metastatic disease at original diagnosis, and cohort 2 had de novo basically metastatic de novo metastatic disease. And you can see the difference is not so prominent in these two particular group. Now, a very well-known trial, the PROFOUND trial, which we have, which had basically addressed the role of HRR mutation, addressed the looking at the safety and efficacy of olaparib, which is a PARP inhibitor. So this was the first trial which looked at a phase 3 randomized trial, which looked at the efficacy and safety of olaparib versus novel hormonal agents in patients with HRR mutant CRPC. The eligibility criteria only required failure of prior treatment with NHA or a metastatic or prior treatment with the NHA for metastatic PC or CRPC. So they had taken patients who had who was centrally reviewed for the qualifying HRR mutation in the tumor tissue, and there was no patient had not taken any prior treatment with a PARP inhibitor or DNA damaging cytotoxic chemotherapy. So they are divided into cohort A and cohort B. Cohort A basically looked at two important prominent mutation. One is the BRCA1 and 2 and the ATM. And they were given olaparib in a 2:1 ratio. And cohort B was basically other HRR mutation. Olaparib was also given in 2:1 ratio. So the primary endpoint was radiological PFS, and the key secondary endpoint was the overall response rate, the PFS by the BICR, and the time to pain progression and overall survival, and also looked at the safety and the tolerability. So this is the largest prospective trial, basically, which studied, which screened the patient for HRR in patients who are metastatic CRPC by a central tumor tissue angiostensing. So the prostate tissue, how they acquired it, they either acquired it by the primary, from the primary tissue, or from the specimen which they got it from the TERP, or they do the metastatic biopsy. The sample was the sample required at the sample needs to be formalin fixed and paraffin embedded, and minimum tissue surface area was around 5 to 7.5 millimeter, and the minimum of 20% tumor content was required for testing. They did the DNA isolation from the archived samples. Bone sample which required DNA calcification was not good for the DNA quality, and so before doing the DNA isolation, they looked at the DNA quality and quantity, and the testing performance was done from the NGS and the that is Foundation 1 CDS NGS, and they looked at all the deleterious or suspected mutation. So what was basically the looking at this trial, The profound met its primary endpoint. The profound met its primary endpoint means that the olaparib showed that there was a significant improvement of the radiological PFS by the in patient who had altered BRCA1, 2, and ATM. That is a cohort A group. Now, what happened to the other group? That is the cohort B, cohort A and B group. Commonly, if you see on the right side, it also statistically significant and clinical meaningful improvement was seen in this group. When they combine both cohort A and B, you can see a difference of around 49% in 6 months and around 22.13% in 12 months. So what was up looking at the profound data, the HRR mutation prevalence in the screen population, a qualifying HRR alteration was observed in nearly 27.9%, approximately 30% of the patient with, who had a successful test result. And here also you can see a BRCA2 was predominant of around 8.7%, BRCA1 of around 1%. So the when you talk about the prevalence of HRR mutation in genes which are included in cohort A was around 16%. Like I said, BRCA2 was a main factor, around 9%. In cohort B, the most common mutation which was found was CDK12. And remaining 11 genes, they looked at 15 genes basically. And the remaining 11 genes in cohort B was contributing only 6%. So the distribution of alteration in HRR genes within the randomized population reflected that observed in the screened population. Nearly 7.2% of HRR mutation randomized patient had a mutation in more than one gene. Most frequently, so there was not only that all the patient had only one mutation, around 7% mutation, they had one more mutation apart from it. So most frequently they were seen with BRCA2 or CDK12. Remember, these two are the prominent mutation in either of the cohort. BRCA2 was nearly 9%, CDK12 was around basically around 6%. So now, what are the current testing practices which we normally do for HRR mutation? Remember, we look at two important components. We look at the germline and the somatic component. And the commonly performed test is blood or tissue. And in a blood, we normally do the ctDNA testing. Also, we do the CTC testing. But remember, ctDNA and CTC testing, basically circulating tumor cell testing, is something which we are not commonly getting a good results, is not commonly performed. So patients were selected for the study based on the prospective tissue testing, and the first screening part basically used to include they used to take the sample to the foundation medicine lab, and then screening 2 basically looked at randomization and based and the patient were blood sample from enrolled patient for germline testing was also done. So screening 1 and screening part 2, basically the screening part 1, they looked at tumor and the plasma sample. Plasma sample, they looked at the ctDNA, and the tumor sample, they looked at the HRR gene mutation. The screening part 2, which was done after 4 weeks, basically they looked at the similar thing, and some of the patients, they did the CTC analysis at baseline, regular intervals on treatment on disease progression. The purpose was basically to see whether the ctDNA works in this group of patient or not. Plasma sample, ctDNA, blood samples have been collected for retrospective analysis, recognizing that tissue adequacy would necessitate a broader algorithm in practice. Remember, in a prostate cancer, finding a tissue sample at a time of metastasis is something which is very difficult. So the modality which they looked at, primary modality they looked in the profound was basically the tissue. So the profound basically they, like I said, they divided into cohort A and cohort B. And the qualifying HRR gene alteration was identified by prospective tissue testing using a pre-specified panel of 15 genes involved directly or indirectly in HRR. So they had cohort A, the predominant 3-1, BRCA1, 2, and ATM. Cohort B had basically the most prominent was a CDK12. Apart from they had used the different RAD51, PAL-B, FANCL, and CHEK1 and 2. So like I said, a total 15 genes were tested as a subset of the genes. Genes were selected based on the mechanistic role in the HRR clinical efficacy data, heredity risk, and the most characterized, the best characterized were the BRCA1, 2, and ATM, and genes in the cohort B were considered exploratory. So there is a evidence of clinical activity of olaparib patient with alteration in genes other than BRCA1 and 2. This is what Profound has shown. And so it is not like that only BRCA1 and 2 are the one who are going to respond. So 97% of the patients who are randomized were based on the alteration in 8 out of 15 single genes. And the exploratory analysis suggested that patient with BRCA alteration derived the most benefit. However, there is an evidence of clinical activity of olaparib patient with alteration in non-BRCA genes. But gene level analysis is complex. It is difficult because the sample size is very less. You can see like, RAD51, RAD54, the number of volume is very less. But you can see on this chart, you can see gene by gene, the radiological PFS. BRCA2 showed a very good response. CDK2 also showed response, but less than what we see in other. ATM, which was part of the cohort A, was not showing good response. CHEK2 showed RAD51B and L showed a very good response. Here the response was almost on par with the BRCA2. So different gene, but the problem is that you cannot extrapolate based on this small chart because the numbers were very less. So core needle was the most common collection method, but had the lowest test success rate. Higher testing success rate were from the radical prostatectomy and TRP. So trephine biopsy had the highest success rate, but this was based on a very few samples and not representative of all bone biopsies, which were mostly core needle. So you can see here the trephine biopsy, the most common collection method in the whole system. So metastasis happens predominantly in the bone tissue, and the challenge which we face when we do a bone biopsy is that the success rate is not very high because of decalcification and trying to get the adequate DNA material. I think this is something all of us know, that the bone is not a good sample to be sent for genetic mutation. So for a metastatic sample, the highest success was there when you do the sampling from the lymph node, liver, or other soft tissue areas. You can probability of getting a tissue DNA is around 70%. But bone and lung are something which are challenging, where the probability of finding is hardly 40 to 50%. And remember one thing, archival tissue is something which is feasible, and you can think about sending it for the NGS analysis. Now, this is the small area which is going to, this is basically trying to tell us that the majority of the sample which are assessed in the studies were the archived core biopsy derived from the primary tumor. So this is the archival status. You can see around approximately 90% was archival, 9% was the newly collected. And if you see the primary and metastatic was hardly 15 to 16%, but primary was approximately more than 85%. And this is the way they collected the sample, and the majority was a core needle biopsy, and radical prostatectomy was the next. Looking at the organ, the major organ was the prostate, and lymph node was around 7%, whereas the bone was around 4%. And another chart which is very important to know is the sample age. So they had patients who were more than 10 years, approximately 15% were more than 10 years, 5 to 10% for the majority, which was around 30%, and 3 to 5 years was around 23%. So less than 5 years in this study group, nearly 50% of the patient, more than 50% of the patient, they were basically less than 5 years. Now, looking at the sample breakdown, when you talk about the newly collected versus the archived tissue, so in a screen patient, samples were mainly derived from the archived, which I mentioned previously, nearly 90% was archived, and in the metastatic setting. You can see here, newly collected around 9%, primary from the primary tissue of origin 3%, but metastatic 5%. In archived, basically nearly almost all the sample which was collected was from the prostate. So a slightly higher prevalence of HRR gene alteration was found in the metastatic tumor tissue. Now, talking about the prevalence of HRR gene alteration in primary and metastatic tumor tissue, so they had the, when you compare the prevalence, they found that when you collected the tissue from the metastatic tissue as compared to primary tissue, primary tumor, the prevalence was around 32% in the metastatic tumor as compared to the primary, which was around 27%. So the prostatic tissue, it was the probability of getting a alteration was slightly on the lower side, but not significant. So talking about the patient HRR mutation tissue test success rate. So this is the patient flow through screening for HRR alteration with the central NGS. Remember, this study was a very big study, a global study, which had taken patients from 20 countries. Cohort A had around 200, more than 200 patients. So nearly 4,000 patients, they entered screening, and nearly 4,047 patients, the samples were tested and reported, and they found that nearly 70% of patients, they were successful. But out of this patient, around 400 patients, 387 patients were randomized over 22 months, 250 in the cohort A and 142 in the cohort B. So HRR eligibility was not fulfilled in more than 3,000 patients, and only the eligibility criteria was filled in around 380 patients. The main reason for test failure in this study was, the most frequent reason for test failure was the DNA extraction failure. That means not getting sufficient DNA yield to proceed with the testing. So had pathological failure of around not adequate tumor content of around 22%. Insufficient DNA yield was there in nearly 45%, and failure after DNA extraction, that means the DNA quantity was not adequate for NGS, was around 22%. So a good number of patients had a failure in getting a DNA extraction. So now this is another thing which tries to give us an answer, is that from where we should take a sample. So test success was higher with the newly collected versus the archived sample. Samples derived from the metastatic site versus the primary tumor origin. So they have put up a chart where they have seen archived versus newly collected sample, primary versus metastatic. And the most common reason for test failure were different depending upon the age of the sample. Archived samples are more likely to fail at the stage of DNA extraction, and newly collected samples are most likely to fail at the pathological review. So during the review period, the high probability that they will get basically they will fail. So the proportion of samples with a successful test, you can see the newly collected sample scores better than the archived. And when you talk about from where you have taken, metastatic scores better than the primary tumor. Now, this is a tumor testing success rate by organ side. You can see on the right side, the lymph node highest, then comes the lung, liver, prostate, and lastly is the bone. So majority of the samples, remember, were collected from the prostatic tissue. However, the testing success rate for prostate disease was very low, around 55 to 60% compared with other organ types. The highest was with the lymph node. So the testing success rate for prostate tissue was relatively low versus other organs, which could be due to high proportion of prostatic samples were derived from the archived core needle biopsy, which had varying amount of tissue remaining in the block because many initial diagnostic workup was already done. A variable nuclear density of the tissue depended on the part of the prostate sample and the amount of tumor in the core. And testing success was lowest in bone, as we all know that because of the degradation of nucleic acid, which can happen because of the decalcification. The highest success which we can get in a metastatic setting was in the lymph node sample. So this is the second important thing, is that when we are talking about the archived sample, how good is the success rate when they collected sample of less than 1 year, less than 5 years, or more than 10 years. So samples are collected over a broad timeline, like we have discussed that there was some nearly 25% of the patient where the sample was in the age of around more than 10 years also. So test success rate declined with sample age. However, 50% of the sample aged more than 10 years was still able to yield genomic results. So I think even if you get an archived tissue, we should not forget that, because nearly 50% of the people you can get the DNA testing. But the highest success rate was seen in more recently collected samples. Like in less than 3 years, it was around 70%, 66 to 70%. Whereas older sample, they had less probability that you will find a good DNA content because of nucleic acid degradation of impacted by the storage condition. So what are the key takeaway from this trial, looking at the NGS of tumor tissue in that PROFOUND trial? That the tissue testing is recognized as a current gold standard, but is challenged in prostate cancer because by tissue fail rates by the NGS gene panel testing. So in the PROFOUND trial, analysis explored the impact of different factors on the tissue testing, including collection method. They look at the age, they look at what type of tissue to be done. And talking about the collection method, they found that the core needle biopsies yielded lower success rate than the samples from the prostatectomies, and were the most common collection method in the study. Small residual tissue sample sizes barely reaching the minimum tissue volume input may be a limiting factor for successful test outcome. Talking about the age of the sample, older sample, less success rate. Successful testing was possible in both archival, because in the trial they found nearly 47% patient the archival prostatic tissue they were able to get. But recently collected sample, those which are less than 33 years, the probability of getting a success rate was around 70%. Tissue was a one which is most commonly tested, but testing success rate were higher for the metastatic sample than the primary sample, which may be due to higher cellularity and tumor content, and that most primary samples were archived. In PROFOUND, common reason for test failure were that sample did not meet pathological requirement or had insufficient yields of DNA after extraction. This highlights the critical importance of selecting high quality samples and optimization of tissue collection to improve the NGS success rates. So these are the basically looking at the quality of NGS based Hrr mutation testing relies on the provision of adequate sample. You need to be, it should be optimally fixed basically within 8 to 12 hours, 24 hours in a 10% neutral buffered formalin. And this is the thing which is basically told to part of the pathologist workup, that section has to be appropriately done, at least 50 microM section thickness, and for the optimal DNA extraction. And it should be reviewed by the pathologist to determine the adequacy, whether sample quality is sufficient with more than 20% cell, and whether it has got more than 1,000 cells. So pathologist must determine whether the specimen contains sufficient neoplastic material, that is more than 20%, and it has got enough tumor cell, that is more than 1,000, for a test to be successfully conducted.
Sir, sorry for interrupt you. Can you conclude your talk?
Yeah, I think just one more slide. So this is the algorithm for the use of more than one diagnostic option. So we do plasma and tissue testing. Nowadays, most of the time we do both the testing to get a better result. And the preferred algorithm is that initially tissue testing is done, followed by a germline mutation testing if there is an insufficient sample or no tissue, and in the absence of validated ctDNA testing. So moving from HRR, BRCA to HRR, I think we have now gone beyond BRCA. We are now looking at other mutation also. And because ultimately, end of the day, there is a drug which is available which can be given to the patient. Now, these are the NCCN recommendation looking at which place we should do this mutation. So NCCN does recommend that in a high risk population also early stage, you can do it. But in a metastatic CRPC state or metastatic hormone positive patient, we should do the BRCA mutation. This is the NCCN guideline recommendation where we should do the mutation testing. I think this is the last slide. This is just a sample report about it. Thank you, everyone.
Thank you, Tejinder, for an extensive review. It was appearing very difficult topic, but I think fairly understandable in this. I was just thinking that earlier period of there were hardly and nobody used to go for all these tests. I mean, do you think that it is going to be the future for all the genetic tests that will be done for all prostate cancers?
Ideally, yes, sir. I never used to do testing regularly, but I had started doing it in the metastatic CRPC state. Even though the NCCN guideline does put that you can do it in a high risk, loco-regionally advanced disease also. But I feel that in a metastatic CRPC state, it has got a usage because there's one drug which is available. In the last 6 months, basically, my experience is that out of 10, one patient will have mutation testing positive. 2 of my patients, they came out to be checked 2, and one patient came out to be CDK 12 positive. So 1 out of 10, the probability of finding the mutation even in Indian setting also. It is just that we are not doing it.
Yeah, right. I think maybe it was expensive, therefore it was not done, or?
So yeah, yes, sir. So why I am doing it? Because company is providing it for free of cost right now.
Oh.
So, but what you said is very right. The HRR testing will cost around 20 to 25,000. I think cost will come down once the utility or our usage also will increase.
Yeah, right. Well, thank you. Any other question by anybody? I couldn't see anything in the question and answer in the chat. Dr. Narasimha, anybody is there?
I think there are no questions in the question box.
Yeah.
But excellent presentation, comprehensively summarizing the whole thing. I think I'll just make a comment here, mostly for the urology colleagues. Most of the times the initial diagnosis is by the urologist who does a biopsy most often. So most of the times when we clinically know that we are dealing with a metastatic prostate cancer patient, we tend to take 3 or 4 cores, and then mostly to document, look at the Gleason and some small variations that are possible in the histopathology. But I think now that we have an actionable drug which requires a comprehensive tissue based analysis, I think the time has now come where we'll have to sample more and more, even when we know that these patients are metastatic, and archive them properly so that they come handy when it is required.
Thank you.
Sir. Yeah.
Yeah, right. Fully agree. I think we can move ahead. I think with the time is just right, 5 minutes late we are. And I think Dr. Srivastava Narasimha, you are there as a moderator for the case-based panel discussion. And I'm happy that practically all the panelists are there. I could see in the list, Dr. Amandeep Arora, Dr. Shrikant Atluri, Dr. Rajesh Reddy, Dr. Preetam Dev, Dr. Uday Chandan Khede, Dr. Gautam Panda, Dr. Saurabh Goswami, and Dr. Vinay Babu. I'm sure everybody is there. It's going to be very useful and fruitful discussion. Dr. Narasimha, floor is yours, please.
Thank you, sir. Thank you very much.
Request for the all panelists, can you please open your video?
Yeah. So I will be essentially requesting the coordinator to present my slides. Unfortunately, for some particular reason, my laptop is not working. So I think Gitika, can we move on? Yeah, I welcome all my panelists. This is, I would like to present two cases in this segment and one case in the other segment. We'll try to discuss these points as quickly as possible, which essentially summarizes all the talks that were wonderfully given today till now. So this is about a 50-year-old gentleman who had no family history of malignancies, who had been complaining of dysuria and pelvic pain on and off for about 8 months duration. So he initially was evaluated by a physician who got an ultrasound scan done, which showed prostatomegaly with significant post-void residual urine. And for the back pain, he was referred to an orthopedic surgeon who did an MRI of the LS spine. And he noted that there were multiple metastatic lesions in the thoracic as well as the lumbar vertebrae. Subsequently, a PSA was done, which reported back as 17, and he was then subjected to a prostate biopsy, which reported a Gleason score of 4+4 and a classic acinar adenocarcinoma of the prostate. PSMA PET CT was suggestive of a extensive skeletally metastatic disease, along with multiple nodal mets as well. So he's a 50-year-old male with a metastatic prostate cancer. Next slide, please. So can I start with Amandeep? Amandeep, how do you want to proceed next?
Yeah, so this is Dr. Srikanth here.
Yeah, Dr. Srikanth, yes, please.
Yeah, so 50-year-old gentleman presenting with Gleason 8 and metastatic disease. So it's a hormone-sensitive metastatic prostate cancer. So I think the standard of care now is a doublet therapy. So ADT has to be given. And as discussed by Dr. Mahindra, we give all the options to him. Surgical with medical castration in the form of agonist versus antagonist. And we have to add another agent, which can be an androgen receptor modulator or chemotherapy in the form of docetaxel.
No, given that he is young, he is only 50, he presents with extensive metastatic disease, would you be inclined to consider chemotherapy upfront, or would you start off with a novel hormonal agent?
So there is no head-to-head trials comparing about novel therapeutic agents like abiraterone or enzalutamide and chemotherapy. But given his high volume disease and young status, definitely I would offer him first chemotherapy first with a docetaxel, 6 cycles, like 75 milligram per square meter.
Dr. Gautam is there with us. Dr. Gautam, would you agree with Dr. Srikanth, or would you consider hormonal agent at the moment, or would you do something else?
Sir, I would like to treat him with ADT plus docetaxel plus abiraterone as per the PS1 trial, which has shown PFS as well as OS advantage over ADT plus docetaxel or ADT plus abiraterone actually. Since he is young and fit, he can well tolerate the treatment also.
Yeah, I think as we talked, the Arasens trial has also come out with its results, wherein they have added darolutamide in this segment along with.
Yes, sir. Yes, sir.
Yeah, and
yes, sir.
It has a both cancer-specific survival as well as OS advantage. So, but I think all of us definitely agree that he requires chemotherapy because he is young and his metastatic burden is quite high. Next slide, please. So, Dr. Rajesh, is this a patient for genetic testing? Would you want to do it now, or would you want to do it later?
I would like to do it now, sir, because later on the tissue quality, the blocks quality might come down, and yield might come down. So I would like to get it done now only. He is the perfect candidate, 50 years male with extensive metastatic disease. I would even to like to get somatic as well as germline too.
So you get both somatic as well as germ. So you would essentially do a HRR mutational testing, which will include even the BRCA1 and 2, is it? Or
Yes.
would you like to do BRCA1, 2 separate and then the somatic?
No. HRR panel, complete panel I would like to get.
Yeah.
And
So
I would like to get the MMR testing also to look for microsatellite instability, immunohistochemistry.
okay.
So if now I'll get it and keep it. Later on, it might be required.
Later. How often, I mean, in your practice, have you found microsatellite instability high reported in metastatic prostate cancer patients?
So far, from our institute, we have sent 10 samples for microsatellite instability. Only one we got positive.
I think that's a big
And
number.
that patient was had colorectal malignancies previously.
Okay.
So case of Lynch syndrome.
Yeah. So yeah, that's the point that it's quite valid here. So if there is a strong family history of other malignancies, I think even MSI will play a major role even upfront. Otherwise, I think the yield with MSI positivity is pretty low. Dr. Gautam, do you agree, or do you have any difference in opinion?
No, sir. Completely agree with you.
Yeah. Next slide, please. So next slide. I think all of this have been very well dealt by Dr. Tejinder. So these are the patients who should ideally be tested by germline mutations. Those with a positive family history for cancer, regardless of age of disease. Those with known DDR mutations in the family, especially the BRCA2, and those with prostate cancer, even if they have a negative family history and have metastatic prostate cancer at presentation, or when they have a biochemical relapse after initial curative treatment failure, or even in those patients who have high risk or intermediate risk localized prostate cancer, and those with ductal or intraductal histology. This I borrowed from the NCCN guidelines. Unfortunately, the EAU and ESMO do not as yet support to all of these indications, but most of the guidelines do definitely agree that germline mutations are useful in younger patients with metastatic disease and those with a positive family history of cancer. Next slide, please. So this was way back in 2018, where we were still not having olaparib. So he was started on hormonal therapy with degarelix, and he received the standard dose 3-weekly regimen of docetaxel. In the post 3 cycles, his PSA came down from 17 to 2.5, and PSMA PET after 4 cycles showed a very good response. He did not have significant adverse events. So our colleague medical oncologist continued with 8 cycles of docetaxel and completed it in October 2018. The Nadir PSA at the end of chemotherapy was 0.9. He was continued on monthly degarelix. Next slide, please. By about another 6 months, so 1 year from the time of diagnosis, he started having recurrent urinary symptoms as well as lower back pain. His PSA was now rising from 0.9 to 5, and by then we had initial data on the PROFOUND trial. So we repeated a TRUS biopsy of the prostate, which still showed active disease. It was sent for NGS testing to Foundation 1 because HRR mutational testing was not uniformly available in the country. The Foundation 1 reported ATM loss in exons 46 to 63. Dr. Gautam, now that there is a actionable mutation, how would you approach? We were talking of 2019, but I think it's more relevant to talk of today. So how would you approach?
So, it basically depends on the patient's performance status as well as the affordability.
Yeah.
And if the patient is affordable, we can start. There are basically multiple options like hormonal therapy, chemotherapy, and the olaparib also. So, depending after counseling the patient, we can start with either of these. There are pros and cons to each of these. There are certain side effects which we have to monitor, which we have to consider before starting the therapy.
Okay. So what would be your next choice of drug?
So since olaparib is still costly, we would like to start with abiraterone for this patient, abiraterone or enzalutamide
Abiraterone
or
or
cabazitaxel, enzalutamide or cabazitaxel for
so
this
all
patient.
options are basically open, both the novel hormonal agents as well as the second line chemotherapy.
Yes, sir.
Yeah. Dr. Preetham, if you were managing this patient, would you consider giving him PSMA tag lutetium therapy or any one of those PSMA tag therapies right now, or would you want to reserve it to a later date? Because I think there now data from Australia to say that patient at CRPC is an ideal candidate for PSMA tag lutetium therapy.
So not right now, not upfront at this point of time. I would always want to reserve it at an where none of the therapy is working for him. So I would always prefer as an novel the second line of chemotherapy or the newer hormonal agents like abiraterone or the enzalutamide at this point of time, sir.
Dr. Gautam, how often have you found cabazitaxel to be useful immediately after docetaxel has failed?
Sir, it has worked quite a few times, especially the time interval between the end of treatment of docetaxel and the recurrence basically matters. As the time is long, the response is also better.
Okay. So, so this here, it was only a 6-month interval. So probably, like you said, you would probably consider giving him a hormonal agent rather than cabazitaxel, if that's what I.
Yes, sir.
Yeah. Dr. Saurabh, he has been having sacral pain constantly. So what would be your indication to, palliate the pain? Would you like to do the palliative RT to the sacral area and then start him off on the second line drug, or would you wait and watch for response with the drug?
So if patient is in pain, I definitely recommend to start with the palliative radiation, whether it is 20 degree 5 fraction or a 8 degree single fraction. That may help him to cover that for later. It will provide the stability plus pain control for coming 3 to 6 months. It will be a good response to the palliative form of radiation to that area.
Okay. Yeah, I think if the patient is in considerable pain, it's probably important for us to palliate the pain as well, because the medication systemic therapy in itself may not be really helpful. Yeah, can I have the, I think all of us agree that there is a role of olaparib right now. And like Dr. Gautam said, barring the cost considerations, he would probably look at olaparib. But since cost is on the higher side, he would go for a novel hormonal agent. Next slide, please. So this was discussed in the tumor board, and since he was having a progressive disease, it was and with a very low PSA even to begin with, because most of the medical oncologists in the tumor board felt that PSA of 17 for a metastatic disease with a Gleason of 4+4 was slightly disproportionate. So based on what we had from the foundation one, we went. The medical oncologist felt that adding carboplatin to the docetaxel would benefit this patient, and that's exactly what was done to the patient. And following 3 cycles, patient seemed to clinically do well. His pains had gone down, his performance status improved, and his PSA came down from 5 to 1.2. So I wanted to ask Dr. Gautam here. Dr. Gautam, how often do you consider carboplatin in your?
So generally, we don't start with the platinum, though it is considered if the patient is BRCA mutated or HRR mutated, they respond well to platinum. We use when we have exhausted all the lines of treatment, and if the patient is not affording for any other treatment options, we can use it. Here they might have used, because the patient has already progressed on docetaxel, and adding a platinum might make a sense. So that might have
Yeah. This was back in 2019, but would you agree to this?
No, sir. No, sir.
Yeah. So that's something that I really wanted to understand from you. So if there is an upfront indication to use a platinum agent, can you tell us which are those patients where you would strongly consider platinum right from the beginning?
So platinum is not as such recommended, but it can be considered for patients who are basically HRR mutated, because these patients generally respond well to the platinum.
Okay. Okay. And going back, do you think doing an IHC on a Gleason 4+4 to rule out neuroendocrine elements or so on and so forth is important, or when would you like to do an IHC to rule out neuroendocrine element?
So basically, there are two types of neuroendocrine carcinoma which we encounter in day-to-day practice. Basically, there are pure neuroendocrine carcinoma and there is mixed basically. So the behavior of the tumor is basically dependent on the percentage of the tumor which is neuroendocrine component. So patients who are neuroendocrine component, they are independent of the AR pathway and they generally don't respond to the ADT, but however there is still a controversy to use ADT or not. So these patients are managed as per the treatment lines of the small cell carcinoma lung. So they are treated with platinum plus etoposide. And these patients are basically younger patients. They have low PSA at presentation and they have very aggressive disease also. So when we encounter these type of patients, we can consider starting platinum plus etoposide. And also when a patient progresses till the PSA is low, we may consider to do a re-biopsy.
Okay.
Transformation of the prostate adenocarcinoma.
Okay. Thank you. So subsequently, we did a PSMA PET CT scan, showed a good response. He was started on abiraterone. He is right now doing well, continuing to use abiraterone for almost 2.5 years now. Next slide, please. Yeah, I think I'll skip all this. Next slide, please. Next slide. Yeah. So this is my second case. This is a 71-year-old hypertensive gentleman who presented with vague abdominal symptoms, lower abdominal symptoms, with a master health checkup detected PSA of 101 with a good performance status, I would say. He underwent a CT scan which revealed an enlarged prostate with suspicious prostatic lesion with multiple metastatic deposits in the lumbar spine, bilateral lung parenchyma, small, all abnormal sites of nodal metastasis as well. So he was subsequently referred to us, where we did a PSMA PET CT scan along with a biopsy as well. He had a Gleason 5+5, Gleason 10, that is, with perineural invasion, LVI, and the subsequent IHC which we did not document any neuroendocrine features. We also did a PSMA PET CT scan which showed multiple PSMA-avid lung lesions of variable sizes with multiple lymph nodes and multiple skeletal metastatic lesions as well. So again, a 71-year-old gentleman with extensive metastatic disease with unusual metastatic sites in the lung as well as non-territory lymph nodal metastasis. Next slide, please. So I think coming to the genetic testing part of it, do you think that this is a candidate for genetic testing right away, or would you like to wait? I think I will ask Dr. Amandeep if he has come back. Amandeep? Dr. Preetham?
Sir, although this would be not an upfront case where we do an genetic testing like coming with a metastatic disease, but in the present era, we have a lot of array of drugs with an olaparib which has shown good response, And as Rajesh said, we may lose a specimen later on when we, if we're not doing an upfront. So probably he may help in doing an genetic testing early in the disease and right now. And we can also, it is also helpful when we want to use an olaparib in the later part of the treatment. Yes, sir, we can do an genetic testing in him right now.
Right. Dr. Uday, would you want to do a prostate biopsy, or would you also request your IR colleague to do a lung biopsy in this case as well?
So as we have seen a good presentation from Dr. Tejinder sir, that in spite of this prostatic biopsy, the testing means ratio of diagnosing this gene panel testings are higher in the lymph nodes and the other tissues like lung and liver parenchyma. Definitely, I would like, in spite of this prostate also, I would like to take a biopsy from this lung or liver, other sites, not from bone.
Not from bone, obviously. Yeah, correct. So, do you have now? I mean, now that HRR testing is available, have you sat down with your pathology colleagues and created a specific workflow, or it is again only need-based requests that are generated from your side?
So frankly speaking, means we don't get such sort of patients. Like affordability is the most cost constraint is the one of the major issue, and but like if the cost constraint is not an issue, definitely I would like to continue with this.
Okay.
Yeah.
So, Dr. Rajesh, what would be the preferred sample in case of unsuccessful tissue test? So you've done a prostate biopsy, you have done a lung biopsy.
The best one is lymph node.
Yeah, yeah, lymph
The best
node.
one is lymph node. Lung is not a, preferred organ. The best one is lymph node or any visceral, solid visceral organ like liver. And after that, the prostate itself. And the least one is the bony mets.
Yeah. So, no, you have done this sampling and it has come back as negative. So, would you like to consider germline testing in these patients where the somatic tissue testing negative, or would you assume that since the somatic test is reported negative, there is a less likelihood of non-HRR related disease?
No, I would like to get germline also, sir. Better.
Yeah. So probably when somatic testing is negative and you have a strong and compelling indication regarding HRR mutational HRD present, I think germline would also act as a good surrogate. I think the company has also introduced circulating cells. Has anybody in the panel tried CTC in these settings?
Yes, sir.
What has been your Dr. Rajesh?
We're waiting for the results. Recently, only they started. Previously, they used to sponsor only the tissue, not the circulating tumor cell.
Correct, correct.
We're waiting for the reports.
Correct. Next slide, please. I think these are the indications for germline testing in patients with prostate cancer. The initial slide showed the indications for somatic testing. This is for germline testing. High risk, very high risk regional or metastatic prostate cancer, patients with Ashkenazi Jewish ancestry, a positive history of family cancer, and a family history of high risk germline mutations, especially in the BRCA1 and 2, as well as the Lynch mutations. And those patients who have a cribriform histology, which is a surrogate indicator of genomic instability. Next slide, please. Next slide. I'll just skip all these. I think these have all been very extensively dealt by Dr. Tejinder. Next slide, please. Hello, am I audible?
Yes, sir.
Yeah, next slide, please. Next slide. I think we'll skip all of this. Next slide. Yeah, so coming back to our patient, the patient received 2 subcutaneous injections of Zoladex, goserelin, 3 months apart, and the PSA level after the first and second injections were 19.25 and 89 nanograms per ml. The testosterone level assessment revealed the testosterone to be in castration level. So this is a patient who just received ADT alone and no added treatments. So I think all of us do agree that this is probably not the best way to treat this patient. Now that this patient has progressed on to CRPC in a short period of time, about 6 months. What next? Dr. Preetham?
Yes, sir, with present with an high volume disease, and then he has also progressed within such a short period of time. I would always prefer for docetaxel in this patient, sir. And also, he should have a good ECOG status.
Okay. Okay. Next slide, please. So I think all these are options, but considering that he has a heavy metastatic burden, and if he has a good performance status, docetaxel will be the way forward. Next slide, please. I think I'll skip all these slides. Next slide, please. Next slide. Next slide. So, Dr. Vinay, I wanted to ask you 2 questions specifically. One is, if this patient had only nodal mets with one-off pulmonary met here and there, would you consider him oligometastatic, and would you consider giving radical radiotherapy to the prostate by going by the Stampede trial?
No, considering this patient has visceral mets, so I don't think he is the right candidate for prostate-directed therapy. Yes, if it is a low metastatic, only less than say 5 sites of bone lesions and limited nodal lesions, then I would have considered for prostate-directed therapy, but not in this case, since he has visceral mets. Is not the right candidate.
Not the right candidate. Now, sir, I would like to know about your experience regarding radiotherapy in oligometastatic disease. Have you been doing it, and how have been the results?
No, we have been done hardly 2 cases till now, as of now, in oligometastasis, where we had patients like with 1 or 2 bone mets, mainly in the axial bone mets. So we have directed radiotherapy to the prostate as well as the metastatic site. So metastatic directed therapy. So we have decent results, but long-term results I don't remember. I don't have presently. But yes, we have not treated only the prostate, but we have treated the metastatic directed therapy, the bone sites also.
I think it only makes sense because when the trial published, they were looking at all comers, and only a subgroup analysis showed that radiotherapy is beneficial in low volume disease.
Low volume disease. That's right.
Only they had given metastasis directed therapy, I think the results would be only better.
Correct.
So yeah. So I think that's a key point. We need to understand, especially the urologists, that oligometastatic disease can still be attempted with radical radiotherapy with a reasonable chance of cure, if not cure, at least a reasonably longer overall survival. So it generally skips the urologist's minds that metastatic is metastatic. So we'll have to really discriminate whether these patients are radiotherapy worthy as well. So Dr. Vinay, I would like to continue with you. In your practice in metastatic disease, when do you consider bone strengthening agents? Which drug do you use, and how often do you use them?
Sorry, I didn't get you, sir. Which radionuclide? Did you ask radionuclide?
Not radionuclide, sir. Bone strengthening agents.
Bone strengthening agents. So all metastatic, with bone metastasis, we are using bone strengthening agents, preferably this zoledronic acid on monthly basis. Invariably, all metastatic diseases we are treating with zoledronic acid.
Zoledronic acid. How long do you consider treating them, sir? Or
at least 1 year.
At least 1 year. Okay. Okay. Dr. Gautam, do you think he's right now, this patient right now is a candidate for chemotherapy or any other alternative therapy like lutetium therapy?
Sir, this patient should be offered chemotherapy if he is fit. Lutetium PSMA is recommended as per the Vision trial, and it included patients who have at least progressed on a taxane and NHA. So currently he has only received the ADT. So as per the trial, he is not a candidate for lutetium PSA. We have used for some patients who are not fit for chemotherapy and who are not fit for other agents also. So if he is fit for chemotherapy, we should go first for the chemotherapy and plus or minus radiotherapy to the painful sites basically.
Okay, thank you. Next slide. Yeah. I think we are running short of time, so I will probably not delve too much on these. What has been shown is that denosumab, rank ligand inhibitors, are much better compared to zoledronic acid, but most of us are conventionally used to using zoledronic acid as far as cost constraints are concerned. But probably the time to first skeletal related event and a progression of a skeletal lesion is more delayed when we use denosumab over zoledronic acid. So coming back to our patient, this patient went on to receive abiraterone. He was reluctant for chemotherapy. That is the main reason why he did not receive chemotherapy in the first instance. He received abiraterone along with prednisolone and zoledronic acid. A PSMA PET CT scan performed in after a year showed an increase in PSMA avidity in the skeletal lesions, and the patient was scheduled for EBRT to the painful areas. Dr. Vinay again. Sir, have you encountered PSA drop after treating bone lesions?
No, we don't perform PSA. Generally, these patients after palliative radiation, they go to, medical oncologist, but I am not really sure about, because we don't follow with the patients.
Okay. Dr. Gautam, do you see a transient PSA drop in patients who just received palliative RT?
No, so actually we don't do actually after palliative RT. These patients are asked to do PSA after some cycles of chemotherapy or on a follow-up.
Okay.
So
this is just out of curiosity I asked, because I know if all these disease, which is because a painful site is probably the most active disease site as well, assuming because it is to the patient. So is there a possibility that by giving directed therapy like radiotherapy, if there could be some level of PSA response? Just a curious question. I know it doesn't have any scientific basis. Next slide.
Yes, yeah, we have never asked PSA immediately after radiation.
Correct. So now he has progressed on abiraterone. This was in this is an old case, 2017. Now, do you think that there is patient is still unwilling for chemotherapy? He has progressed on abiraterone. Would you like to consider HRR mutational testing now, or go ahead with enzalutamide? Dr. Gautam?
Sir, if the patient is willing for HRR testing, it should be done as soon as possible, and the report will take approximately 2 to 3 weeks in India basically. So if he is not symptomatic, we can start after 2 to 3 weeks. If he is symptomatic, we can start with if not chemotherapy, we can do other tests like MSI and MSI and MMR testing, and other options are after getting the HRR testing, we can start with olaparib if it is mutated, and if he is not willing for all of this, we can consider for lutetium PSMA.
Lutetium PSMA. Okay. I'm sure all of us have used it. So how often have you used phosphosterol, HORN1 in particular, and what is your experience with it?
Sorry, sir, I didn't get it.
HORN1. Phosphosterol.
Therapy, sir.
HORN1,
sir. Actually, we have not used much basically. For few patients, actually, I think 2 or 3, because this we have got a lot of drugs in hand before the patient progresses. So we have used for quite a few patients, but for these patients we usually get the echo done. We start on aspirin because it is a basically thrombotic agent. So there is a risk associated with it, and it is not associated with improvement in OS basically. So since we have got a lot of agents in hand, we rarely use it nowadays.
Yeah, can I take a parallel opinion from the urology colleagues? Srikanth, any opinion?
Yes. So my teacher, Dr. Jagdish Kulkarni, used to use a lot of One, especially for those patients who are not affording. So we used to give 120 milligram, and we used to start them on antiplatelets also. And as Preetham said, there were a lot of thromboembolic events. And we also saw cardiac events like cardiopulmonary events from DVT leading to pulmonary embolism.
Okay. But do you still consider using it at some point of time in your treatment plan, or you have given it up?
Only when patient is not affording rest of the other agents and like very low poor income class, then we use one.
Okay. One quick
Yes,
opinion as well.
Yes, sir. Can I say something, sir?
Yeah, yes.
Yes, sir. So we have used oral metronomic chemotherapy for few patients who are not affording, who are very, who are in basically very poor economic strata. And we have seen that if the oral metronomic chemotherapy used in the earlier line of therapy, it gives good result. Basically, we use it in a later line of therapy when we have exhausted the chemotherapy, hormone therapy, lutetium PSMA. So the results are bad. For few patients who have used in earlier lines, and it has given a good result. One patient had a PFS of approximately 4 years on the OMCT only.
Yeah.
So
currently, so that you mentioned, I have to tell you that we have been doing an RCT. We have already accrued about 38 patients. We are using metronomic chemotherapy immediately after completion of docetaxel in those patients who have shown a response to docetaxel with a PSA response of more than 50%, who have maintained a negligible toxicity profile during their chemotherapeutic regimen. We have been running this for about 2.5 years now, and like you mentioned, a lot of patients are doing well. So only time will tell. We want to accrue 100 patients and then see how it goes. So I'm glad that somebody else is also doing it on similar lines. So I think we're running behind schedule. I would like to stop at this point in time. Any comments from the panelists?
Sir, can I say something? Yeah.
Yes.
Sir, regarding bone strengthening agents in metastatic HSPC.
HSPC.
Yeah, in metastatic HSPC, only if the DEXA scan shows if T-score less than minus 2.5 in osteoporotic range, then only to use.
Yeah.
The two initial challenging with the vitamin D and calcium. And, at 3 months, zoledronic acid, again at 12 months, if there is osteoporotic range. Otherwise, we don't need to use anything in HSPC. In CRPC, once a month for 12 months, the zoledronic acid or denosumab. But after 12 months, no data about it.
I think the recommendation is up to 24 months and not beyond 24 months.
Yes.
But what I feel is, if cost is not a constraint, we should strongly consider denosumab. We don't do it because most of our treatments are not affordable. I think zoledronic acid really, if you look at the data available, really does not alter the skeletal related events significantly. It is more like that we are covering it up as a protocol rather than having any major benefit. Having said that, I also use zoledronic acid mostly on my patients because of cost constraints. I thought I'll just bring this up during the discussion so that wherever possible we should start using denosumab.
Yes.
Any other comments from the panelists, or can we close? Yeah, I think I thank all my panelists for actively contributing for enhanced knowledge of management of prostate cancer patients. I really appreciate your participation and time. May I now request Srivastava sir to kindly give the closing remarks, sir.
Thank you, Dr. Narasimha. It was really wonderful, and I'm sure a lot of people were there who will be benefited. In depth, we have discussed so many things, and I think Dr. Narasimha, I must thank you all for organizing such a wonderful meeting, and thanks AstraZeneca for supporting. Thank you very much. And Dr. Narasimha, you have some final comments, or we can close it now?
That's it, sir. I just wanted to hear from you any comments regarding the program and any scope for improvement or betterment for the subsequent programs.
Yeah, sure. I think this was very nice. I think this is a nice way. And the only thing which I was thinking that I'm not sure how many postgraduate students are there. They should also be there to get benefit from such a wonderful discussion. So maybe next time also we can ask the either AstraZeneca or who is organizing that they should invite many more postgraduate students.
Yes. Thank you very much, everyone, for your precious time. It's a working day. I think all of you have cut short your work, compromised on family time to participate in this discussion. Thank you, AstraZeneca, for arranging the whole event. Thank you very much.
Thank you.
Thank you, sir. Good night,
Thank you.
everyone.
Good night.
Thank you, everyone.
Thank you, sir.
Thank you. Good night.
Thank you, everyone.